Okay, good morning, everybody, and some good evenings of some people. Today was very honored to have people from all over the world. We have people from Hawaii. We have, I think I better take out my pass. Sorry about that. You know, I was still wearing masks. But anyway, we have people from Hawaii. We have people from Hong Kong. We have people from Vancouver, United States, different places. We have also from Philippines. We have also from Singapore, Malaysia. Wow, a lot of people from all over the world. So quite a big group of people at different places. So very, very good. And first of all, I thank you very much to spending the time with us today. We welcome you to our special webinar. And so today we are very excited to share with you about how slowing the onset and progression of diabetic kidney disease, so-called DKD, okay? So before we start, we just want to put a little bit sort of administration skill set to make sure that everybody understand what we're trying to do. And then we'll go from there. Certainly, we will be basically today we have a lot of people might have questions, and you know, also, you know what, I need to set up the Facebook too. Sorry, I forgot to do that. We're too busy on setting up the stuff, so we're now setting up the Facebook. Some people want me to put on Facebook. Actually, today, first of all, we encourage everybody to ask a lot of questions, and we will able to answer you at the end of the session. And also, you can place question in the chat box. We have a lot of the question there we can ask, and then we can encourage you to ask. And I'm sure last seminar, Professor Chan answered every single question. They love it. People said this is real good. And also, this session is recorded, so at the end of the day, we could give you the replay and so forth, and you can able to follow up through email and so forth. Now, let me introduce myself first. I'm Andrew Lau. I am president CTT of Mrs Wong. I'm the creator of Lowsutea. I was an ICU nurse and have 40 years of medical and healthcare experience. I was the former vice president of Baxter Asia Pacific and retired from Abbott Laboratory as a regional director. I introduced IV catheters and CABD dialysis therapy throughout Asia Pacific and saved many lives. So I know dialysis very well. I also know diabetic very well because I took care of many, many patients. And joining here today is so wonderful. We have Corey Carino, Corey is a multimedia celebrity. I mean, we're so honored to have her because she is a very famous person in Philippines. On top of that, she is the former Philippine president of Carino, 1940-1953. Very famous people. On top of that, she is a healthcare educator, author of many best-selling books, Forever Young, for example. She also featured many beauty and healthy tips for her work program. She's a council member of Philippine Red Cross and support various humanitarian activities. So we're so honored to have Corey be part of the participation as the co-host speakers. And she's going to ask Larry some very good questions, actually. So start us off. Joining us also with Professor Laurence Chan, very famous professor. He is a professor of medicine of nephrology and surgery of the University of Colorado School of Medicine. He's also a member of Transplant Center of University of Colorado Hospital. Dr. Chan specialized in application of MR and other molecular biomarker in allografts rejection. His medical research focused on effort at different immunosuppression drugs on cellular metabolism, and he worked in renal transplantation, chronic renal failure, and hypertension. So this is truly a renowned, very qualified person. Tell you about DKD. It's so great to have Larry to help us to explain. Let me just summarize very quickly what we're trying to do objectively today. We try to understand the cause and early signs symptom of diabetic kidney disease, DKD. So we have to know underline what is the mechanism, develop DKD, and explore new treatment option and prevention, and also learn the tip how to slow down the onset and progressions on DKD. And that's so important because with knowing that, at least you can prevent you to really end up with dialysis. That is so good to have that, right? So I hope that everybody have a chance to really learn more. And so we can able to really prevent DKD and get a better health. And we're the maker of Lowsutea, which help pre-diabetic and diabetes patients to maintain better blood sugar level. We have shown many clients able to postpone their pre-diabetic conversion and delay the onset of diabetic complication. It does actually have patient studies showing lower the blood sugar, plus also lower the LDL, bad cholesterol, blood pressure, and detox. And plus, we have 5 programs, including diet, exercise, weight control, blood tracking, and all the education that help you, including the weekly webinar we have, which Lowsutea user can greater awareness with their own health and prevent diabetic complication. And we kind of hold their hands, so to speak, throughout the diabetic journey to maintain better health. So we also create a poll question. And you can see that on the button of your screen has a poll. So you click on it and we'll run a very quick poll just to get a bit of understanding the type of people we are listening and so forth. And so that way, we will give you back some of the answer at the end of the day and see what the people have. So while you're doing the poll questioning, without further delay, we will jump right into the panel discussion. So I will ask Corey to join me on this panel discussion. Corey, thank you very much.
Good morning, Andrew.
Yeah, thank you.
And thank you for inviting me. I'm so happy to be here with the distinguished presence of Dr. Laurence Chan and with you, Andrew, for discovering and developing Lowsutea. In this way, we can make everyone healthy.
Absolutely, thank you. So, Corey, I understand you have some question to ask Professor Chan. Maybe you can take this time to ask Professor Chan.
Okay, my questions are all lifestyle related.
Okay, good.
Because a lot of people go through their daily lives now that there's no more risk of COVID, well, hardly any risk of COVID. People are going out, no more social distancing, and they forget to wear their masks. And so
Right.
we remain vulnerable, right?
Right.
Always, every single
Absolutely.
minute of our lives, we are exposed to microbes, bacteria, viruses. My question is, some doctors that I've interviewed during this pandemic have already said it, that the one who are most vulnerable to being victimized by COVID-19 are those who have diabetes.
Yeah.
Dr. Larry.
Yeah. Well, that's definitely true because diabetes is a multi-organs disease, not just high blood sugar. And all those patients with diabetes will have relatively immune compromised. So they are more susceptible to infections. And also once they get the infection, they are more frail and easily get sicker than rest of the population because they might have high blood pressure, their heart may not be doing that well, they might have infection in other area. So taking this together, their mortality rate, in addition to being highly susceptible to infection, especially COVID, their complication rate is also high. And again, the mortality rate is also high among this patient. And diabetes being so widely, you can say high prevalence in the community, that means you hear about that so often. And a lot of people might have diabetes and they didn't know they have that, and they get the disease, and so they have those complications. So taking all this together, it is an important issue to appreciate, and it's an important problem for us to have education, to make people to be aware of that. So like any health issue, it's both individual, the patient, but it's also the community and the society to help to prevent the disease and take care of those patients.
Matter of fact, just to update, in Hong Kong, quite number of people who are diabetes got COVID and died, and they're older folks too. So it's really sad. And matter of fact, in the early days, majority of people death are actually diabetic related also, just to keep you updated. So it's really something that you don't want to be in that boat, you know?
So these are all what we call risk factors. Risk factor of the disease, risk factor of the individual or their age, and also the risk factor, how well they control the disease. If they didn't control their disease well, that means they are more susceptible to complication. And in addition to all the cardiovascular disease, other complication is infection and susceptible to the epidemic as well.
Mm-hmm. Dr. Larry, you said that a lot of people, and I quote from your reply, a lot of people don't know that they have diabetes. What are the warning signs? For most
well, I think it's a worldwide problem. And prevalence or instance or whatever you call it is a commonly disease, which is not necessarily called acquired. Some of them may be because your genetic, your background, your family. But the majority of the cause is because of your lifestyle, your behavior, your overweight, your habit of eating. So they are eventually develop what we call metabolic syndrome and then diabetes. So there's really a silent epidemic, what we call it now. The epidemic word is so well aware of. But this is a silent epidemic, which means that a lot of people may have the disease and they didn't know that unless they go and check it. And depending on what test they do, of course, they check their blood sugar, but depending on when they check their blood sugar. And of course, now we have the A1C, which give you an average. But more than that, it's possible that a lot of people, before they go to check it, they may have high blood sugar for a long time without symptoms. Because normally you don't have symptoms. You may have increase in frequency of urination, a little bit thirsty, drink more water. But this a little bit later, but early on, we don't know. So in fact, if you can say average patient, when they come to a doctor and to say health checkup, and they found to have what we call either diabetes or pre-diabetic. And this is based on their lab test, their urine, their blood test. But before that, it's possible for many years they already harboring the disease without knowing it. So this is something that we need to have. What you are doing, which is perfect, is education, generate more public awareness so that we can have prevention. By the time they have the disease, the prevention may be a little late. So the prevention started should be before they have the disease. And then the complication of diabetes, heart problem, high blood pressure, and of course what we're going to talk about is diabetic kidney disease. It occurs after they have diabetes. And again, they are also silent. A lot of individuals didn't know they have diabetic kidney disease. And actually, they might have that many years before that. So exactly the same as diabetes per se. When they diagnose they have diabetes, they probably might have the disease 3, 4, or 5 years before that. And weight is a good index. You can take it this way because diabetes, you have type 1, type 2. Type 1 is juvenile onset, which is difficult to prevent because a lot of them is because of the early onset, many factors that lead to the insulin cell of the pancreas fail, so they don't have enough insulin. But the majority of diabetes, what we talk about nowadays about the silent epidemic, is type 2 diabetes, which usually at our onset. In the past, usually is after 40 years old. But now, we are seeing more and more patients develop this type 2 diabetes before they are 40 years old. And that's why we have so many patients with diabetes nowadays that we didn't know that is when we diagnosed it. But in fact, there's another silent not necessarily majority, but a silent proportion of population might have the disease, pre-diabetic or diabetic, without knowing it.
Okay, Dr. Larry, one last question, because I know we have to go into the main part of the seminar actually, but can you reverse diabetes?
Reverse, well, okay, it's depending on what's the time scale you want to reverse it. You want to reverse an individual, or you want to reverse, look at the public health thinking, society thinking. Society, public health, yes, it's possible because now we have 12 to 15% of the population have diabetes worldwide, vary from society to society, and depending on how diligent you look at that. Can we reverse this trend? Yes, we can, provided we work together, take action. So how many action we have to take?
Mm-hmm.
Well, individual is one, of course, that's important, but it's so difficult. Once you have the disease, it will be very difficult to reverse it. But you can prevent the complication. You can prevent the organ that got affected get worse. So it slow down the progression, slow down the disease process, less complication, so that the individual, the patient, can live longer. So even they have diabetes, if they are well taken care of by the patient itself, by the family, by the doctors, by the healthcare system, so that they don't have to worry there's no money to buy the medicine, there's no money to do a lot of things, then they can live a long life. They can live till 80 years old, 90 years old. Okay, so in that case, can we say we're reversing it? Well, we're slowing down the process. We're not actually reverse the diabetes itself, but we'll reverse the complication or prevent the complication. In that case, we can say we can reverse. But I'm talking about more than just individual. Now we talk about community, society. And that's a more challenging problem. And we have to be positive. We have to say, yes, we can. We can reverse it.
Yes, we can.
Yes,
Yeah,
we can.
then we have to start from individual, community, society. Society is just not necessarily the city, the village,
The
but also
government.
professional society, voluntary society, institute, organization like Corey, what you are doing in your community or worldwide, what Angel is doing, public education. And then we need to develop a good system, a system of integrated public versus private partnership. And then hopefully we can change the public policy, which is also important. Public policy, we deal with government now, right? So from non-government organization, countrywide to worldwide or United Nations, to individual countries, public health policy, public care policy, hospital practice, pharmacy. And of course, don't forget about the other area, which is we need to understand the disease more. How do we understand? We need to do more research, both basic research as well as applied research, both in the university as well as in the community. We need big data, collect all the information. Now we are in a position to be available to have all the data integrated together. So public health is important. Governmental involvement is important. Society involvement is important. And of course, individual. Individual require a good education program. And Corey, what you are doing is will be recommended because it's by doing that, one patient at a time, one individual at a time, so that we can build a community for healthcare, for prevention.
Yes. Okay,
And
one more thing.
Yeah.
Dr. Larry, what is the one thing, all our friends who are watching us right now, what is the one thing that we can do right now, any lifestyle change right now that can prevent diabetes?
Well, start early. Early start, that's important. You don't have diabetes yet? Yeah, then eventually you will get older. And if you keep doing what you're doing without watching your diet, if you just stay around watching television, don't do enough exercise, eventually you'll get diabetes. So watch out about what you are doing now. If you are getting close to you may develop that, then you want to prevent it by watching your diet, do exercise, be aware of what you are doing. And you can say communication, education, that's the other thing. And if you have that, then find out what are the culprits, the risk factor, minimize them, minimize them. So if blood sugar is high, then minimize the blood sugar. If blood pressure is not as adequate, control, make sure you seek appropriate advice. Keep your blood pressure under better control. Well, when you get old, invariably you're going to have a cholesterol problem. And what is the right level of cholesterol? Again, it keeps changing. The mark always keep changing. Used to be at that level is okay, but 5 or 10 years later, no, it's no. You need to have it lower. And used to think that, oh, you only have to worry about cholesterol when you are 50. No, when you are 40, you have to think about that. And if you are elevated, then you better watch out your diet. And if you still can't control that, then there's medicine available for that. So all this added together is education, public awareness.
So you're saying then that diabetes or having diabetes is not really a death sentence. We can improve the quality of our life and extend our life.
Yeah, definitely we can. And since later on we're going to talk about diabetes, and again, I'm going to stress another point. Invariably, diabetic patient eventually may have some kidney disease, and it's a matter of time. What you want is that you want to extend that as long as possible. And even if you have diabetic kidney disease, doesn't mean that it will go downhill all the way. You want to change the slope from getting your kidney disease problem in 5 years, you want to extend it to 10, 20, or even 30 years. When you are 80 or 90 years old, maybe you are less worried. We want to find that there's various methods, from lifestyle changes to diet to the right kind of medicine, the right kind of advice, avoid risk toxic substance that worsening the kidney function, and of course, is to preserve whatever kidney function they have to avoid replacing it. So this is a slogan that I have going to put it down later in the talk, is preserving what you have, all right, instead of replacing it. And that's the key thing. Of course, we have so many patients on dialysis, and it's okay when they're on dialysis. If they do it well, they can still live a reasonable, good life and extend their productivity 10, 20, or even 30 years. And in this country, in US, we have 500,000 individuals on dialysis or transplant. Around the world, it's probably we can time by 3 or 4, so about 2 million individuals on dialysis. And if you expand it, how many people are with kidney disease that eventually leading it? There will be a number of millions, and more than half of them are due to diabetes. We want to make sure that the number doesn't continue to rise as quick as what we have in the last 30 years. We want to make sure a lot of patients, they may be heading that way, but we want to preserve whatever small amount of kidney function they have, not getting worse, so that they will not need any dialysis down the road. So preserving the kidney function they have and prevent them from needing dialysis. And this is my message.
Thank you so much, Dr. Larry.
Okay.
Andrew, back to you.
Oh, good. Well, you know,
Okay.
this is very, very good questions. On top of that, I learned a lot. On top of that will be the insight. Larry talk about the, you know, public health and government, everybody together. What's so important is really individual, really required to work on it and take effort. And so we won't get into that boat. It also could be really, like you said, we can just delay the progression, live longer, some kind of so-called reverse it to diabetes, so to speak. But I have a patient which is really come to see me since last year, October, and he really looking forward to hear your insight. She is a 68 years old patient, which is Mrs. Wong, and has diabetic for over 15 years. And as her age at 53, she found out that she had high cholesterol, high blood pressure. The blood pressure went up to 160, 180. Diastolic was 90 over 100. And very quickly, the doctor also said, hey, you have early stage of diabetes. But on the other hand, she doesn't have any symptom. Really, at the end of the day, she don't feel sick. For 8 years, she was saying that, hey, I feel pretty good. Although I do have high blood pressure, cholesterol, but she is continue to enjoy her lifestyle, going to eat whatever, travel with friends. And on the other hand, with that though, good lifestyle, her BMI actually increased to 30. So she gained a lot of weight, okay? And at age 65, the doctor said, hey, you're diabetic, getting worse. So even though you're taking metformin, 2,000 milligrams per day, 1,000 per tab, one in the morning, one at night, her blood sugar was A1C go over 10 to 11% already. And doctor said, hey, look, your blood pressure is still high, 150 over 90, cholesterol, LDL is still 3.8. The doctor said, we got to put you insulin. But she said, wow, I could have gotten insulin, taking a shot. Are you kidding? And she really afraid needle. So last October, she came to see me, and basically we start her on Lowsutea. But at that time, her GFR, which is the glomerular filtration, item that is measure her kidney function, only got 40%. And the doctor said, you get 30%, you require dialysis. And she was scared. That's why she came to see us. And suddenly we let her try Lowsutea, but she still continued taking her 3 drugs, which is Norvac and also Losartan, both are blood pressure pills. And she also taking Lipitor, which is the cholesterol pills, 20 milligram. And she also continued to take metformin, 1,000 milligram 2 times a day. And she started drinking Lowsutea. But fortunately, because of that, we got her to control her diet, exercise, weight control. Her BMI actually came down to 28. She lost some weight. Plus, she bought an Abbott Libby, continued tracking her blood sugar. So her daily blood sugar becomes 7 millimole per liter, or 126 milligram per dil. Her A1C dropped down below 7% versus previously was 10+%. So, and her blood pressure fairly controlled now, 130, 140 around there, and diastolic still about 90. And she really wanted to talk to Dr. Chan, is wondering, okay, now I'm on a GFR 40. Her condition, will it continue to progress to be worse? And since her blood sugar has improved, and she would like to hear Professor Chan's insight, basically.
Well, thank you, Angel. I think this is a wonderful case example to illustrate the various issues that confronting a patient with diabetes. And Mrs. Wong, we have to congratulate you for you are a wonderful patient because you are taking good care of yourself. But looking at the spectrum of the history, when you were diagnosed to have mild diabetes, high blood pressure, and cholesterol, what we normally will label that as called metabolic syndrome. Okay, when you are 53 years old, if you have high blood pressure, and depending on your weight, but for Asian, the weight may be different from what the Western's thinking of the weight. But most of us, the BMI may not be exactly the same, but you might be already slightly on the high side of the weight. And even when you are 53, the blood sugar might be high, but was not that high. But it's possible you might have prediabetes or diabetes many years before that. And it's possible when you're 45 or 40, You are doing well, everything is fine, you didn't really check your blood or anything, but it's very likely you might have what we call insulin resistance. Your body still secrete insulin, but your tissues doesn't really react to your insulin. So in a good example is inflation. Okay, you have the same amount of money, but you didn't buy enough stuff now. Okay, so you already have inflation before you're 53 regarding insulin's currency. So you were taken care of very well by your doctor, but we don't know in between 53 to 65, how frequent was your checkup? I'm sure your kidney function was normal during that time, but kidney function is a very loose term, depending on how they test your blood. If you just check the common parameter called creatinine, then you may not see any changes. And if they use a special formula to calculate to creatinine to what we call GFR, standing for glomerular filtration rate, a very high sounding rate, but basically very simple. When your creatinine is less than 1, it is all called 100%. When your creatinine is 2, this is what I taught medical students, it's 50%. And when you jump to 4, it's 25%. So between age of 53 to 65, 8 years, there was no information, but I believe the GFR might slowly decreasing without you noting it, because creatinine won't show any change at that time. The other interesting parameter people need to be aware of is that need to check urine for albumin. And most of the community now doesn't really aware of that. That is important parameter to check if you have diabetes. Once you have diabetes, at some stage, every other year or annual checkup, need to look for albumin in the urine. If there's higher than normal albumin in your urine, that means your kidney started to have some damage already. So when you are 53 to 65, 8 years, you already noticed to have high cholesterol, high blood pressure. So you are given appropriate medication for blood pressure. But I haven't have the good readout of different blood pressure at different time. And there are some blood pressure medicine better than the other. So they were up to individual doctor who choose it. But there are some blood pressure medicine may have some renal protective effect. They try to make sure, just like engine oil for the car. So car will be a good analogy. You have a car at 40 years old or 53 or so, and you run, everything seems okay, but you didn't know there's something problem because you didn't maintain it well. You didn't give good enough engine oil. And by when you are, so 8 years later, when you go and check out, found out, oh, there's 1 or 2 other problem, but it's fixable, so you fix it. So blood pressure, cholesterol elevation, and blood sugar was not well controlled because A1C was very high. And it's probably not well controlled for several years. And it's not good because if you control it well, maybe your kidney will preserve better function. But no worry, because they are taking good care of you and you are taking good care of yourself. So you are starting on metformin, which is, again, a good drug to be given for people with diabetes, the first line of drug to give, especially when your kidney function was still okay, because metformin is excreted by the kidney. So when your kidney function started to deteriorate, your amount of metformin taken need to be adjusted as well, okay? But anyway, you are on that, but it look as if by itself, the blood sugar was not well controlled, so you rely yourself, self-care, changing lifestyle, watch out your diet and blood sugar, and then when you are on 3 years later, 68, the function seemed to deteriorate in terms of the kidney, but how bad is that? it all depends. If you are really not well controlled your blood sugar, maybe you're much worse. You are controlled maybe a little better, then it will preserve the kidney function. So this is where you are. So the more you control your blood sugar, the more you control your blood pressure, and watch out your activity, diet, various things. Hopefully, it will preserve that kidney function for many, many more years to come and avoid dialysis. So congratulate for taking good care of yourself.
Wow, that is very, very good tips for Mrs. Wong. She will be really greatly appreciate your tips to indicated that she's doing the right thing because she is so aggressive now, controlling her blood sugar, started drinking Lowsutea and tracking her blood sugar every day with Abbott Libby. Plus her dieting is really changed quite a bit, really going down the low carb diet. Plus she also started doing exercise. So Larry, for now, why don't we start off without further delay? Can we start off your lecture? So we start with that, and we can all understanding what need to do, how to slow down onset or progression of diabetic kidney disease. Would that be okay, Larry?
Okay, so I already
Yeah, you got your
uploaded.
slides up already.
So
You
can
can
see
actually,
that?
yeah, go ahead, please.
Okay, so basically we'll go back to the same case example. So what we want to do, what's going on? What is diabetic kidney disease, and how can we slow the onset? And once it's started to have diabetic kidney disease, how do we slow down the progression so that we can avoid the dialysis? So this is a general summary about what I'm going to talk about. Well, just in case I was trained as a kidney doctor, so I always want to start, what is the function of the kidney? So the function of the kidney, most of us do have two kidneys, and together, they work together to filter the waste, extra fluid from our body, so that will make the urine, control the volumes. And in addition, they also control the blood pressure through the various hormones that affect our blood vessel, and also control our red blood cells, which is the epogen you heard about that we have for the stimulation of red blood cell formation from a bone marrow, vitamin D for our bone, and also for our immune system as well. So the kidney is a very important organ. It receives a lot of blood from the body each day, and then make it clean so that it doesn't cause problem to our other organ. So diabetic kidney disease is a relatively new term. We used to call it by a diabetic nephropathy, but we embrace it into a more, also another term called chronic kidney disease, CKD. It's a kidney disease that slowly progresses over years rather than acute kidney disease. And diabetic kidney disease is the most commonest cause of chronic kidney disease. And as you know, that 1 in 3 adults, so mostly a type 2 diabetic patient, may develop diabetic kidney disease. And as I told you before, that it's a silent disease, just like diabetes. A lot of us patients might have kidney damage without knowing it until it's so that there's some problem in the urine, because normally we don't really do biopsy using a needle to find what's going on in the kidney. We're just based on the size of the kidney. If we are doing x-ray or something, looking at the urine, unless you're looking in the albumin or protein, you didn't know that the urine is affected. If you just measure creatinine, as I told you before, the creatinine of 1 or so, or less than 1, you thought it's normal, but actually the kidney already have some damage without showing those numbers. So we need to be aware of that. And And that's why I say it occurs slowly over many years. And the good news is that we can take steps to protect the kidney and to prevent and delay the kidney damage. And hopefully, many of those patients with diabetic kidney disease don't end up what we call end-stage kidney disease when their GFR is less than 20% and they may need dialysis or transplantation. And so diabetes is a silent epidemic. That's what I said before. And I just show you the evidence of that based on various data that come out from the World International Diabetes Federations chart here about the highest incidence is United States, but China is catching up in terms of percentage of adult in the populations that have the disease. So 13 to 14% is the number, and then the country has gone down. But take the number with different thinking. This is based on study. So if you didn't do good enough study, surveying enough the population, you may not get good enough data. So put it this way, India is only 8%. We don't know. Maybe it's true because the Indian population, their diet is more vegetarian, maybe less meat, and then maybe less sugar. So maybe they will have less chances of have that. But Southeast Asia, the incidence of diabetes and prevalence is really high as well, especially based on the data in the United States of the different ethnic population. Latino, Asian population, especially Southeast Asian population, the islander, Sonora, all those Pacific islander, the incidence of diabetes, in fact, is higher than Caucasians in America. And furthermore, the percentage of individual, I'm talking about America, for diabetic patients to develop into kidney disease is also higher. So I just want to use this as a warning about data, and more research from society, from community, from public health need to really get a good idea about all this so that they can have a healthcare planning in addition to implementation of care of the patient when they develop disease, but to implement procedure for prevention as well as lifestyle changes, facility and initiative to promote lifestyle changes, diet, regulation if possible that is needed, and of course educator community, public and private partnership in providing better data and then better research for prevention and for medication to develop better care for the patient. But this is a table that I like to remind everyone about the how they defined it. It's based on blood sugar profile, whether it's fasting blood sugar or use the A1C. But A1C is the most commonest thing that we do in the past 10 years now. So basically, you just take your blood, doesn't matter any time, and the percentage they get from it give you an idea about your blood sugar over the last 2 or 3 months time. And most healthy individual will want the number to be less than 5.6. And a lot of people, when they're reaching age of 40 or above, a lot of individual is about 5.7. And in fact, this number also what we call criteria, also like the goalpost shifting. It used to be, they say for pre-diabetic, you have to be 5.9 or above to be called pre-diabetic. But in the last 2 years, we shifted down to 5.7. So that means there will be more patients with pre-diabetic. The same thing about diabetes. They say you have to be above 6.5 now. But before it was say 6.9, about 6.9, you have diabetes. So these are the things that we need to be aware of. In most healthcare checkup, like annual checkup, we go to a doctor, we need to ask for a test, even if you are 40 years old. It's important to get an idea how your blood sugar profile is about. In fact, even in the Western community, not every individual have that check when they are 40 or 50. Yes, I think most people do that. It's just like colonoscopy test. How old is that when you need to do the colonoscopy test? Well, it used to be much older, but now people shift it down. So, and afterwards, how often do you check it? Annually, of course, is important, but for people who are at this range, pre-diabetic or diabetes, you need to check every 3 months or so that to see what's your score. And this is the thing that we need to be aware. So, and then this is an important slide. So what's the natural history? And we can relate to Ms. Wong's in the case on this picture as well. So probably when Ms. Wong was 53, she was, okay, let me see. Okay, she was seeing around this time, yeah, 53. But it's possible that she might have pre-diabetic many years before that. She might have that 45 or so at that time, many years. So she might have insulin resistance. And we have a better term nowadays called metabolic syndrome. Insulin resistant with or without obesity, okay? And she might have high cholesterol at that time. And it's possible when she was claimed to have clinical type 2 diabetes, some of them may require treatment like metformin, but some doctor maybe ask patients just watch out their diet, increase their activity so that they will decrease weight and maybe their A1C will go drop down. But during this time, there's already changes in the kidney, which we don't usually talk about that. And the two most important things I'm going to talk about, and then of course blood pressure, but they are high blood pressure is so common. So even if you have high blood pressure, you might not call it metabolic syndrome or pre-diabetic. But if you have pre-diabetic or diabetic, then of course, when you have high blood pressure, it's already indicate there's something going on in the kidney. Because kidney is one of the main organ that regulate the volume. Blood pressure is based on the function of the volume, the water that accumulated in the body, number one. Number two is the reactivity of the blood vessel, the stiffness of the blood vessel, hardening of the blood vessel, whether they have cholesterol, but there's also something else in addition to cholesterol. So when the vessels are hardening, they will have high blood pressure. But there's high blood pressure you can measure, but there's also high blood pressure you cannot measure with through your arm. Those are small vessel changes, which are the capillaries changes. And that's can be related to high blood sugar. Even before you have clinical diabetes, the high blood sugar will have metabolic changes that lead to deposit of certain substance, which I can show you later. So all this are what we call functional changes and structural changes. So functional changes, basically, I talk about kidney, renal is kidney, hemodynamic. The word means blood pressure, flow. So it's volume changes already. So this functional changes start very early, you see, even before you call the patient diabetic. And then this word hyperfiltration and glomerular, which I can show you later as a picture. Hyperfiltration, filtrate is blood flow. Hyper is too much. When you have too much sugar in the blood, you will cause high flow, high flux, just like your sprinkler system. Imagine like a sprinkler system. When the sprinkler system outlet is squeezed a little bit, the pipe is squeezed, so the blood will flow through that much faster because they have to hyperfiltrate to get through. And glomerular is a unit of kidney. We have 1 million glomeruli for one kidney, okay? So we have a million, one of the million of the units of high blood pressure, basically. And then structural changes are actually what you can see in picture, substance that deposit in the glomerular membrane where we go through the filter. Just like you have the filter paper for your coffee, okay? The coffee filter stuck with a lot of junks there. And those junk are from the blood sugar that alter, change around. So the coffee didn't go through properly. And when it didn't go through properly, they will go something else with thickening and then leaking as well. So become overflow to something else. So imagine your coffee filter machine with the filter paper was the wrong kind of filter paper because there are too much deposit of the basement membrane. So it's overflow. So the coffee spill off. So that's the spill off the albumin, the protein. And then you have some sort of structural changes and then microvascular small vessel changes. And these are the changes happening in the kidney. So functional and structural, and both of them can lead to high blood pressure. So what can we find out early sign instead of doing a surgery or doing a biopsy, which is using a needle to take something out from the kidney, which is invasive? We can tell by doing some tests. Simple tests, just checking the urine, microalbuminuria or proteinuria. If the blockage is too much, you will have large amount of protein. Albumin is one type of protein. So you can detect it. This diagram was made 20 years ago. So 20 years later, we got so many new advances, new things. And there are so many new things we can measure in the blood or in the urine. And I will tell you later about the way we can tell what's going on in the kidney just by looking at the urine or the blood. Some of you probably heard of liquid biopsy. It's a very fashionable term for people who want to check if they have cancer or somebody who have cancer, they want to see what type of thing. You can just draw the blood and then based on the gene or some of the molecule, DNA or RNA, you can tell what type of cancer and the progression of cancer based on the liquid, which is either urine or blood. And in diabetes, we can have the same thing as well. And around here, the creatinine, which is the marker of kidney function that we commonly use in the past 60 years, it doesn't rise that much, but it's only later on, so many years later, that come with this. And then if it's less than 20% of the kidney functions remain, we may talk about dialysis of transplant. And I'm glad that Mrs. Wong is doing fine. She's not on this stage yet, but I'm sure there's some kidney issue there. And it looks as if she's everything under good control. So we can expand this year. We can double it. So only 10 years, you haven't reached this far. So probably she will never reach this, hopefully. So how soon people get to this depends on how well one take care of oneself. In addition to the advice from information you get from educator or provider healthcare provider or dietitian. So I spend so much time on this because it's important. This is most of the common diabetes in the kidney. But type 1 diabetes, juvenile onset, have the similar sequence, but it's much, much different. And some of them are much shorter since they start early in the age. And since the number of patients are not that many, so I'm focusing primarily on the most commonest one, which is adult onset type 2 diabetes. Okay, let's move on. So I talk about functional and structural changes. So this is a very simplistic view that high blood sugar can damage the blood vessel and the kidney tissues that lead into high blood pressure and kidney damage. And the kidney damage from eventually hyperfiltration. The good analogy for hyperfiltration is similar to having a car. It's already not that well, but you still want to run at a very high speed. Not only that, you use second gear to run on that. So you are using second gear to run the kidneys, it's hyperfiltration. And by doing that, and with a lot of changes in the membranes, you have albumin. So there's a blockage of the filter paper of the coffee machine, so they got spill off and more spill off. You got a lot of coffee on the table. And if getting worse, you flood it. So you have kidney failure. And if we do a biopsy, you will see those changes in the kidney. But as I told you before, it's possible we can avoid doing that. These are just the picture, but to illustrate what I told you. So don't pay too much attention to that, but just to listen to me that we have two kidneys, they all at this back, right? Two kidney, and each kidney have almost 1 million of this unit called glomeruli. And when the blood sugar is high, this kind of like our filter paper or coffee filter, they become thickened because they are deposits, chunks that deposit there. So that you spill off the protein, spill off the albumin. And then if it gets worse, it will becomes a lot of scarring. So diabetic kidney, hyperfiltration. So it's running on second gear, hyperfiltration. So actually just looking at the size, it's not going to tell you. And in fact, some of the diabetic kidney size are getting a little bit bigger than average kidney. Our normal kidney is probably for Asians about, the lengthwise is 11 centimeters probably. But for diabetic kidney can be slightly enlarged to about 14 centimeters. And around here is about 4 centimeters. And kidney is very adaptive. So why do they hyperfiltrate? Because they try to adapt to the problem of the high blood sugar. They want to try to get rid of the extra blood sugar, so they work harder. It's just like our car. It's not running that well. It's so slow. So when you're going the slope, they may slightly to skid a little bit. So you change to second gear and try to press the accelerator, try to run on that. But you'll see at the end of the road, you'll see that it might be overheated and there may be some other problem. So this is the analogy I have. And the consequence with the second gear and in the kidney hyperfiltration will be scarring. And this is what happened to our kidney. And this is just an illustration of different stages. Just like microscopy. This meant for people who really want to see what's inside, but I just basically say this is probably early stage, late stage scarring, a lot of scar, and then with the scarring, then you have albumin in the urine. And this graph, well, you can understand that. These are the amount of albumin back in the urine. So you can get a sample of urine, you check it, and you are this low, that's good. And most of us, when you're normal, you shouldn't have any albumin in the urine. So this is for average kidney patient, not kidney patient, diabetic patient. may or may not have kidney disease. And when they have diabetes, for the first few years, they may not have albumin in the urine. They may still have high blood sugar, but damage doesn't changes overnight. It takes times. So there's a number of years develop. So by 9 years or so, you started to have albumin in the urine. And as the kidney go worse and worse, then more and more urine goes up. And why this drop? Because the kidney is not working. Patient already have high blood pressure. It's not doing its job. And that's why they don't put up that much urine. Of course, then when you measure your urine albumin, you don't have that. This is just to give you some sort of basic understanding of how the kidney work. And you heard from Andrew about GFR, and this is the term called glomerular filtration rate. There are so many different ways of measuring it. You can actually do it like a chemical test, infuse something, and then check the blood level of the substance and the urine substance to see how long does it take to get rid of the substance. Then another way is just measure the creatine, CR. And CR is a naturally occurring chemical in the body, breakdown of the muscle creatine. And it varies from individual to individual, but the rate of excretion are really constant. For athletes, football players, they may excrete a lot of creatinine from their urine. For female, they excrete less. And when the kidney is not doing the good job, the excretion of creatinine will drop. Then the blood creatinine will go up. So you can use the creatinine level in the blood, use a special formula to calculate into what we call GFR. And this is same as the last slide about years with high blood sugar. So if you have high blood sugar, starting high blood sugar, as I told you before, you change to second gear, so the kidney become hyperfiltrate, so they work harder. Originally it's 100% around here. So for the first few years about high blood sugar or diabetes, not that well controlled, the GFR actually higher than normal. And by the time you have what we call clinical nephropathy, is diabetic kidney disease, is the older term, the creatinine may still be normal, but there are still a lot of scarring in the kidney. So 10 to 0 to 12 years or so. That's the average for even well-controlled diabetic patients. Take about 12 years or so before they have some changes in the kidney that can be seen or that can be diagnosed. Doesn't mean they didn't have that here. It's that you might not be able to find it depending on what test you do. And then they will slowly decrease. And how the slope decrease depending on how well you take care of yourself. If you take good care of yourself, it will go this way. And you may never have kidney failure when you are 90 or 100 years old. And for this particular example individual, it dropped to less than 20% of the GFR or creatinine. And the level, I use it as an example for most patients, or in fact, I taught medical students, when creatinine is about 1, you call it 100%. Well, this is the US unit. In Asian, some of the Asian country, or UK or European, they use international unit. It's probably like 100 international unit per DL. But I use 1, it's much easier to remember. If it's 1 milligram per DL, I consider as within roughly normal. When you double it, so what we call doubling, it's 50%, you drop to 50%. You drop any further, you'll be 4. And it's now this time people will talk about dialysis. And for Mrs. Wong, don't have to worry. I think you're only around here, I think, because for female, they try to have a different formula and slightly 40%. So if you control well and take good care of yourself, it will be just like this. So when you're 80, maybe you are still at this level, doesn't need to worry that much about kidney failure. So it all depends how well you take good care of yourself and how well your health provider helping you to do that. Okay, so I just use this as a combination so that you know. So this is the first graph I show you. The first graph I show you about creatinine clearance, hyperfiltration and drop off. And then this is the albumin excretion that when you have problem. And this is the point I want to make, that serum creatinine, which we check from your blood, and most of us are at a level like here, this level, very low. And how does it relate to GFR creatinine clearance? You see, it's not a strict direct correlation, because when you are less than 1, you probably won't see any changes in the GFR at all if you use this formula. So early prevention and slowing down of progression of diabetic kidney disease need to start early, even before. So if you take Miss Wong's situation, when she was first seen at age of 53, which was 15 or 18 years ago, her kidney function probably is around here as normal. And she have some early intervention proportion. And even now, her doctor said that her GFR is here, which is what they call 40%. Well, there's still a lot of room for improvement or prevention from deterioration. So this is a window for conservative management. Try to preserve the kidney function. Let it stay around that way. Don't let it drop to below 30 or even here. If it's around here, then we need to talk about dialysis and other treatment. So it's possible. We just need to be vigilant and careful and be aggressive about that. So those are the simple thinking about functional changes, structural changes, how it lead to high blood pressure and kidney damage. This is a more detailed diagram just to explain, just give you a vision and give you some hope that better treatment is on the way. Why? Because we just talk about the metabolic changes, hemodynamic changes, but there are a lot of research over the past 20 years. We try to find out what's going on when you have high blood sugar in the cellular level, in the molecular level of the individual with diabetes. So take simple thing from the top, metabolic, so you have high blood sugar. When you have too much of blood sugar there, the first thing is that they want to, metabolism is conversion, like a currency, changing from one to the other around the world. So when you have too much US dollar, you want to change it to pounds or to euro. And some of them may not be that good, auto ruble. And then those are the chemical that might have damaged to the cells. H is what we call advanced glycation end product. Polio is another glucose compound that make the cells not do its own job. Artery thickened, and so will cause the leakiness, the overflow, and other structural problem. And hemodynamic is the hormone that affect the tonicity of the blood vessel, the thickness of the blood vessel, and the constriction. And this RAS is the local hormone renin angiotensin system. It affect the blood pressure, so the blood pressure will go up. And most of the individual taking blood pressure medicine, like Ms. Wong, taking one of the blood pressure medicine, and is a renin-angiotensin system inhibitor. So this is increased. So we use a drug to antagonize it. Endothelin is another local hormone, constrict the blood vessel or the capillary. And research is on the way that there's an antagonist. And actually, I was working on this antagonist about 30 years ago, and I didn't realize now people are trying to see if they can make it into a drug that you can take so that you can lower the blood pressure at the same time will minimize the damage. So both of this can lead to a new term called reactive oxygen species. And those are called mediator or chemicals cause inflammation. Even COVID affect our lung, our epithelium, the spike protein. With the oxygen metabolism, they will generate reactive oxygen species, and that cause tissue damage. And all these three also controlled by the more subtle aspect, which is gene regulation, the master of the gene, DNA, RNA, and then through RNA, DNA, it will be the mediator called transcriptor, and then function, and then growth factor. Why we have a scarring after we have a cut, and then it didn't grow that well because the growth factor is there and help us to heal, but it didn't heal that well. That become a scar, ugly scar, cytokines, all those things. So all this lead to the function and structure we can see in the old days by microscopy, biopsy. Functional by measuring the protein, by measuring the blood pressure, and measure the electrolyte. And this is the picture of diabetic nephropathy. And what we use to diagnose microalbuminuria, protein in the urine, GFR, and if you use what we call liquid biopsy, we can take your blood and measure the gene or the whatever chemical that we can use. In the new methodology, we call omic, O-M-I-C-S, either protein omics, genomic, or metabolic, using the new machine that we have to measure those chemicals. So it's almost like a fishing expedition. See if you catch up anything, and then from there you find out whether. But there's real science there. What is that? Because by understanding this process, you know where is the problem. You know what's part of the engine you need to fix, just like a car. When you have, now you are stuck on the mountain after using a second gear. You can't start, so you have to do the diagnosis. But if you have all this diagnosis, you can figure that out, and you can find way to fix it. And that's why there are new potential therapeutic strategy based on what we know here. We can develop drug, beta-RS antagonists to control blood pressure, an inhibitor of that. Substance can get rid of some of the substance. Growth factor, they are not good. Then we develop an anti-growth factor. If we don't have something in the nature, if we know the molecule, we can synthesize it and make a molecule out of that. So there's always hope. And then there's always new strategy. So the aim is that we want to preserve the kidney function and prevent us from replacing it using dialysis or transplant. So that's the aim. And that's why we want to control the blood pressure and control the blood sugar. And of all this, we need early start. So this is just a simplistic view, just to remember A, B, C, D, E. A, A1C, so it's blood sugar. B, blood pressure. But think more in depth, not just the blood pressure, what you can measure, but blood pressure of the small unit of the kidney, glomeruli. Cholesterol, what is the good cholesterol, what's the bad cholesterol, but also understand that what are the substance that convert to cholesterol, not just the food, but some of the sugar can convert to cholesterol as well. So diet and supplement are just as important. And above all, ABCDE is exercise, lifestyle changes. So these are important things for you to bear in mind. These are take-home message. And talking about diet and food, remember that blood sugar comes from so many different ways. There are good sugar, bad sugar, and most of them are metabolism of the body. We eat something, food, starch, many things, it will eventually convert, metabolize, and then form sugar. And there are also substances that normally don't have sugar. And in the body, the liver, the kidney, they have a metabolic process called glucose. Okay, glucose is sugar. Neo is new genesis, gluconeogenesis. Even though they are not sugar, the body will make it into sugar. So that's very important. And also, not sugar make equal. Glucose is bad, but fructose is even worse. Glucose plus fructose is white sugar, table sugar. Table sugar consists of fructose and glucose. So if you just have table sugar, glucose is bad, but fructose is metabolized and then getting even worse chemical that ruin our body. And I can show you a picture a little bit later. But what I'm trying to tell you is that it's metabolism of the body as a whole. And from diet, from different type of diet, some are good. Just take fruit, for example. You think all fruits are good. Well, it depends. Some fruit are not as good as the others because they have a lot of fructose. So it depends what fruit is that. The worst one is, of course, the high fructose corn syrup. And this is a manufacture based on the regular sugar cane and then concentrated, make into this high fructose corn syrup. And most of the soft drink are made up of the high fructose corn syrup. And question why we have such a silent epidemic of diabetes or metabolic syndrome. Well, a lot of publication, a lot of speaker has been talking about high fructose corn syrup, especially my friends Richard Johnson wrote a lot of essay and book about the evil of high fructose corn syrup and how they affect the body and develop the metabolic syndrome. And with metabolic syndrome, you have insulin resistance, high blood pressure, obesity is key thing. And because of fructose, I told you about the metabolism that can lead to high lipid and high uric acids. And because the liver have to work very hard, all those metabolism conversion. So fatty liver is another silent disease that become more and more among Western population, and it's also true in the Asian population as well. So this is predates cirrhosis, and we do have a lot of liver failure patients needing dialysis, not dialysis, needing liver transplant because of fatty liver and liver failure. And the mechanism is, I say before, endothelial dysfunction from the chemicals, oxidative stress. So metabolic syndrome, yes, is another silent, another epidemic worldwide. And it not only affects the kidney, heart, and liver, and vessel, but actually it might affect the brain. And there are some study relating to Alzheimer's disease and metabolic syndrome and high sugar. So everything is interrelated. So diabetic kidney disease basically is a conglomerate of cardiovascular disease and chronic kidney disease as well. and they are multiplied because it's synergistically making the disease worse or making the individual worse. And finishing this off by, since we talk about CKD, another initiative we talk about that is about we need to improve our early diagnosis. How do we improve early diagnosis? Is to find because if we don't check the urine protein, urine albumin, you won't know they have diabetic kidney disease. So that's something that's very important. Important to use the appropriate blood pressure medications. And then lately, there are a lot more new medicine that are available. Some insurance company cover it, some may not cover that. And I'm not going to talk about that, but there are a lot of new medication on the horizon that are available to prevent the worsening of diabetic kidney disease. And again, it's very important once you have kidney disease or early disease, we want to preserve the kidney function. How to preserve kidney function? Avoid risk. And one of the risk factors is taking pain medicine, non-steroidal anti-inflammatory drug. A common drug you take for cold, for headache, for ache, and like Advil and other things, they can all affect the kidney function, and they can lead to worsening of the kidney function. So kidney damage with non-steroidal is a very, very important issue, and we see a lot of patients affected by that. So appropriate consultation is important, but I always think it's always important for the patient understand it. So patient education is the most important thing. Patient advocate, be aware of that, and use urine and blood tests without the biopsy is also the key thing that we are doing. And different stages of kidney, and this is too complicated, you don't have to go through into depth, but the two things is that GFR, which is kidney function, and the other thing is albumin, the protein, the albumin in the urine, and we characterize by the amount or not amount, and then the different stage. So there are 5 stages of chronic kidney disease, 1, 2, 3, and 3A and 3B based on whether they have additional functional changes. And then 4 is just before they need dialysis. So where is Mrs Wong staying now? She's probably around stage 2 to 3, but maybe 3A, which is okay, not that bad. And then still a lot of room for improvement, and there's still a lot of renal reserve there. So need to, and why do we want to have this classification? So that we know where we stand, so that patient can know where they are at that particular moment. And why do they use this here? Because a lot of people, when they are CKD or diabetic kidney disease of stage 1, their creatinine is normal. And the question is that, do they really have kidney disease? Creatinine is normal, may or may not have high blood pressure. Well, if you check their urine for albumin, if they have urine albumin, yes, they are stage 1 already. So it's very likely that Ms. Wong, when she was seeing, when she was 53, but may not be 53, maybe a few years later, she must have some albumin in the urine, or she may be stage 1 because she have a high blood pressure already. So that's stage 1 with diabetes. And now she's only here. So 13 years from here to here, which is good. That means she's taking good care of herself. A lot of my patients or patients I've seen, when they're here and they didn't take good care of self, and especially if they didn't follow strict guidelines, taking pain medicine, going through a lot of unexpected procedure like X-ray or with contrast, which iodinated substance can cause kidney damage, or some other thing that will lead to grade 4 or even stage 5 within 10 years. So for 15 years or 13 years, from stage 1 to stage 3A is good. That means patient is taking good care of herself. So it's the same thing here. Exactly. That's 13 years ago was this. Now we are slightly here, around here, 40 or 50, depending on how good is that number. So here, so we still got a long way to go before we call itself a kidney failure. So safety is important. Always avoid those problems. So what are the risks? So I talk about the pain medicine, contrast for CT or some other test, infections, some drugs, antibiotic that can cause kidney toxicity. And then when their kidney are at certain stage of deterioration, this is GFR, okay? So this is the function. This assuming is already compromised, but not that bad. But this is when you are 40 or so, have to be very careful. So when you use a drug, good doctor always want to see what's patient's kidney function so they can adjust the dose. And as a matter of fact, at the moment, Ms. Wong need to be careful about her metformin, because metformin is excreted by the kidney. And if the kidney is not doing a good job, then it may accumulate. Well, she still need the metformin, but you don't want to use the same dose. Maybe the dose need to be adjusted at some stage. And it's the same thing for other diabetic medicine as well, that if the kidney function is worsening, whatever they are taking before, they have to cut it down, whether it's oral medicine or insulin, so that they won't develop what they call hypoglycemia when they are taking medicine. And if they are controlling blood pressure, these are the things that can affect the kidney function. Because if you get rid of too much fluid while they are on a blood pressure medicine, ACE inhibitor, the regulation is not that good in the kidney. So when you get rid of too much fluid, water too quick, the kidney cells become thirsty, dehydrated. So the kidney function get worse. So they will exaggerate their kidney function. So we always want to preserve kidney function instead of replacing it. And that's a good word, always remember. Preserving kidney function instead of replacing it. Even though I take care of patients on dialysis and take care of patients on transplant, but always tell the patient when they see me, first thing is like preserving what you have, preserving the kidney. And it's possible to preserve it. If you do it well, it won't come down like this. These are years, okay, time. It will go like this. And if you do a horizontal line, it will go on forever. Okay, so that's the thing. And how do we slow down the progression? With kidney protective measure. And this include good blood sugar control, blood pressure control, especially with the right medicine, specific medicine, and medicine that can protect the kidney, and lifestyle changes. And have hope, because help is on the way, because we now understand the mechanism of the kidney, diabetic kidney disease much more than 20 years ago. And a lot of clinical trial is in process. And in a few years' time, we have newer drug available that might be able to help to slow down the progression and even prevention if that's possible. And that's to bear in mind. And this is what I want you to take home about this message. That we don't want to end up like this patient on dialysis. This is a year, this is a documentation from the report, ESRD registry. And this is a year and number of patients per million population. Diabetes is always the number one. And a lot of hypertension patients may still have some diabetic element. So with this together, they are definitely the leading cause. And of course, kidney disease have other forms, inflammation, nephritis, cystic kidney, which is genetic, but we don't want it to happen. But overall, in the United States, there are 500,000 patients on dialysis. In transplant, each year we can only do about 20,000 only. And we accumulate, and organ donor is always limited. So there's always dialysis, the majority of the patient. And we don't want patients to go that direction. If they do have to go that, we want them to be prepared early so that they won't end up dialysis all of a sudden. They are not psychologically prepared and the outcome may not be that good. So this is my take-home message. High blood sugar and high blood pressure work in concert to damage the blood vessel and the organ damage. So keep them as close to normal as possible, and kept blood sugar can help to prevent the long-term complication, not only for the kidney, but for the eye, for the neuropathy, for the heart as well. And what are the targets? Well, we want to keep it as close to normal as possible, so 80 to 120, depending on which unit we use. In Hong Kong and Asia, maybe 4.4 to 6.6, but A1C is much easier to remember. An average of blood sugar level that take around for 1 to 3 months. We want it to be hopefully less than 7 if they are diabetic patient. And if possible, with prevention, we want that to be less than 5.7 to the normal level. And if you are pre-diabetic, 6.7 to 5.7 to 6.4, you want to keep it as low as possible. And keep the blood pressure below 130 to 80. And use appropriate blood pressure medication, especially for diabetic patients. Talk to your prescriber, medical doctor. Is there something else better than what I'm taking? There's always something else better. You can check with them. And most important, diet and exercise. Weight control, limit sugar, carbohydrate, and salt intake. If you're a smoker, quit smoking. Regular exercise activity. And it takes a village to take care of this. And in the beginning, I talked about the multidisciplinary approach, individual versus society. We want a system of healthcare, a system of educator, a system of government and non-government organization, private and public initiative to implement a prevention program, a health care program to minimize this silent epidemic. I think COVID illustrates a good example that if you have the resources, both individual, government, and non-government society work together, I think we are winning. And we want to win in this silent epidemic for diabetes, especially the kidney diabetic disease. Okay, I think this is about all. And then I just have this one to remind you about those parameters. And anyone you ever have A1C check, you need to have it checked. If you have it checked, you need to understand what it means. And you want to keep it as close to 5.7 or below if possible. It may not be easy for diabetic patients because you don't want you to develop low blood sugar, which is hypoglycemia. So whatever it is, you need to know where you stand. You need to know where you stand in terms of this blood sugar profile. And hopefully, enjoy good health and good life. Thank you and welcome questions.
Thank you very much, Larry. This is really a very informative webinar. I think a lot of my clients here, all my listener, probably really appreciate that. What I would do is this. I know Corey has another speaking engagement. She has to go to the Inner Wheels, which is 300 or 500 ladies actually waiting for her. So for her another talks. So I know, Corey, if you need to leave, I really appreciate you actually help us to start off this meeting. Greatly appreciate that. And then what I will do is I will engage with Professor to basically to continue the lecture, answering questions and go from there. Corey, do you have to leave now, or you just let me know? I'm just gonna be basically understand that you have to leave for another engagement. That
Yes.
would be okay. Yeah.
Thank you, Andrew, for putting this together, because definitely education is key.
Yeah.
Knowledge is powerful, and we have to go out there and preach the gospel of wellness.
Yeah, yeah.
Absolutely.
For example, the World Health Organization came out with a bulletin, and I will paraphrase. This was released many years ago, maybe 7, 8 years ago, and I will paraphrase. And it says, mankind is slowly dying from a condition of eating too much and moving less.
Yeah.
You're absolutely right.
Yeah. So this is a short and sweet message, and we need people like you to carry out the gospel. Okay, so it's almost like now you have the motto, you have the action item. You need to
Dr.
preach.
Larry, but I have one question that's been nagging me all this time during your presentation.
Yeah.
The human body needs energy, and we can only get our energy from the food we eat.
Yeah.
So what can we eat to make sure that we are healthy and that we are ensured a long life, a long, fruitful, and energetic life?
Well, then you have to choice. You have the choice of more selective to have food that provide you adequate energy and less toxic substance. So just like you can use, since I talk about cars so much, so it's just like you get the right kind of gas or gasoline. They will produce you enough power, but less toxic substance, okay?
Okay, which leads me to my next question. Do you support the ketogenic diet?
It all depends on individual and which patient, and also what medical condition are they at their stage. If you are just preach to the wider audience or so, and assuming they don't have any particular problem medically, something else, yes, maybe they will have less problem, because when you go through the map that I have, they probably produce less reactive oxygen species. They probably produce less like a fructose mediated pathway.
Right.
So we don't have time to talk into that. Ketogenic diet enter the so-called metabolic pathway at a different angle. So take simple sugar, for instance. When you take sugar, you do glycolysis, which is without oxygen, okay? And then you go through pyruvate. Pyruvate is another chemical. And then through that, they enter the cycle, which we call Krebs cycle. He happened to be my PhD mentor at Oxford. So I understand the metabolic pathway well. And ketogenic diet doesn't go through the glycolytic pathway. It goes somewhere in between through the pyruvate. And then maybe they will, you can say they don't burn off unnecessary energy.
Right.
Because energy is through energy of your body, but we are thinking about energy in the cell as a unit. And there's a different term. and that's through the what we call energy currency is ATP,
Right.
adenyl triphosphate is
Right.
where how it drive the engine. And with keto diet, they are in paper, they are more efficient and they can
It's quite
drive much better. So you can say better mechanical coefficient, right? Like a mechanical engineer. But in some patients, if they already have some metabolic problem, if they are taking medicine for certain thing, it can exacerbate or they are more susceptible to some side
oh,
effect. So
I
I want to
understand.
say it all depends. In general, yes.
Depends.
Just
It
like
depends.
just like a diabetic patient, depending on what stage of your diabetes, you don't want them to have more sugar, so you give them more protein. Is it good? Yes and no. Early on, maybe yes, but to some extent, not too much. If you
Mm,
eat protein, what happened? Our kidney have to do some work to work on the protein because protein give us some other extra energy. So they give more energy to the kidney. So the kidney become exactly what they call hyperfiltration. So they have to run faster to
overworking. Uh-huh.
yeah, and then well, but they may not have sugar there, so they don't produce some of the metabolite I mentioned, AGE, called advanced glycolated substance, which is produced from sugar content. So they don't have that substance, so they won't produce it. But if the kidney function is not that good, you don't want the kidney to work that hard. Just like when your car is run for 10 years, you know that it's coming of age, but still running pretty well on regular highway. But now you're going to go to the top of the mountain, a lot of steep slope. Are you going to take that car through that? It depends. If you've gone through that before, no problem. Yes, go ahead. But if you have some hiccups before, better be careful. And in fact, there are some study also about preserving the kidney function. And we have studies showing that preserving the kidney function by eating less protein. And there's some truth
Mm,
in that. And they say that you can delay the progression in the
I
less
see.
time. But the price to pay is that you lack of the protein, the essential protein. So you have the other side of the coin. It's a double-edged sword.
Okay, so Dr. Larry, are you saying then that the vegetarian diet or to become a vegan is probably more supportive of your kidney health?
I think so, but they still need protein. So depending on what kind of protein they are taking. If like bean curd and other protein, yes, they are good. And in fact, there are some chemical in the bean curd or the bean, soya bean, they actually lower the cholesterol.
Yes.
So there's a lot of, you can say, culture, history support what people are saying. Like
All right.
some Asian diet, originally a lot of vegetable-based diet, but because of changing of the cultures, people shift to the most Western style diet, plus soft drink, soda, which a lot of fructose,
Right.
high fructose corn syrup. Then they added oil to the fire. And that's why that we have the silent epidemic,
Let's see. Thank you so
especially
much.
especially in the susceptible population. Who are the susceptible? Because our ancestry, Asian, didn't really exposed to that before. And now they're exposed to that before. Their gene or their protective mechanism hasn't really developed in such an extent to slow down those toxic effects.
Good. Wow,
So that's the reason.
thank you very much. I think so. Vegetarian
Thank you.
diet is actually the best. Sounds like with soybean, especially protein. Okay, I know. Corey, you need to go now, right? Do you have to leave? You can ask some more questions if you want to. Corey.
Yes,
But I
thank
want
you.
to, comment on Corey's mission about public education, public awareness, and if you have connection to whoever the power to be, that's also even more important. What we need is to be able to change the paradigm. You need more people. You need the critical mass, number one, but you also need the power to be.
I am so honored, deeply honored to be here in this webinar with you, Dr. Chan and Andrew, for putting this all together. Maybe there could be a part 2, strictly Q&A from people all over the world who simply want to know more about their kidney health, at the same time, their overall optimum health with your help, Dr. Larry.
In fact, Corey, we are trying to do one with some of the local Filipino doctors together with Larry to get a formal, not formal,
Right.
but a panel discussion similar to what we have. And I think that would be real good. I think it started real well. That's questions is wonderful. I think that's very related, especially COVID-19 related diabetes. I think that's super, super. Yeah. Well, thank you again, Corey. I know you have to leave, but I'm got some
God bless you.
Okay.
I'll take my Lowsutea after every meal.
Absolutely. Very good. Okay. Wonderful.
Thank you.
Okay,
Bye-bye.
thank you. Bye-bye. Larry, I just want to catch you one more time. This is just in case people want to ask me for questions that relate to you guys. So you can actually write to us at andy@wafong.com or ctt@wafong.com. There's a WhatsApp number, which is 852-6792-8891. This is a WhatsApp number. You can ask questions. We'll try to get back to you. Plus all the so-called, the website and things like that. So you can take a picture if you want to. But there's a question for you, Larry. This question is from Hawaii, from Eugene Young. The question is it better to have 4 small food portions than 3 large portion meals? That's the question that from Eugene asking.
Well, there's no good study to definitely make a definite answer, but from common sense is that after each meal, our blood sugar will go up. And if you spread it out to a smaller meal, the peak sugar level may be less. And if you are susceptible to postprandial means after meals sugar is high, then it makes sense to make that adjustment.
So if you can actually eat 4 small meals, appears to be better because the blood sugar doesn't go way up because you eat less. Is that what is the conclusion?
Yeah, because if you use postprandial as
a measurement, yes.
Yeah.
Okay, that sounds good. Are there any more questions, maybe from the panel? I mean, from my clients all over the world. If you have questions, you can feel free to ask now. We can try to answer. But Larry, I really like that A, B, C, D, E. That is absolute easy to remember. I think this is everybody should got to take this home when they listen to this webinar. A, you have to understand what is A1C. That is so important. B, oh, okay, sorry. Let me stop sharing this first. Are you seeing this now? Okay.
Yeah.
Okay. So sorry. I somehow I got. Oh, okay. Wrong screen I shown. Sorry about that. Oh, okay. Let me share the screen again. Do you see the screen now? Basically, screen on the address, things like that. You take a picture. Is it? Hold on. Eugene, do you see the screen that is with all the information? With the address, everyone can see that, then can see whether that, yes, okay, good. You take a picture of your contact, okay. But let me just summarize. I think to take home is so important to have the A1C, A, B, C, D, E. It's so easy to remember. A is your A1C, measure A1C, make sure that your A1C always try to get down to lower than 6.5% if you are pre-diabetic, or even you have diabetes, you can drive yourself down to 6.5% is okay, because I saw a lot of patients now. The A1C was 10, 11, and so forth, and they somehow now, because the exercise diet, they got their A1C down to under 6.5. So it is real, it's achievable. So I thought maybe that is a good objective for them to continue to pursue that, at least under 7, but they also they were able to be real, got down to below 6.5%. Second, B is your blood pressure. It's so important. Get your blood pressure low to 130 to 80. I mean, that is so important because, you know, I've been talking about blood pressure so many times, but a lot of people, you know, just forgot about blood pressure, just think about blood sugar, but not blood pressure. So that is important. C, or cholesterol. One more question on cholesterol. What will be the target for our cholesterol? Will be LDL cholesterol more important, or just overall cholesterol? Because I did talk about triglyceride and all that.
LDL always.
LDL, right? So the LDL is under, in Hong Kong, should be about under 2.5 or about 2.5 with the right target, should give them.
Yeah, in the other unit will be less than 70, and also depend on risk factor. Risk factor means that whether they have cardiovascular disease based on their checkup, like a CT or whatever, angiogram or calcium score. Okay, so if they do have calcium score high, then they need to even more aggressive with their LDL lowering, and also family history.
Okay, if less LDL less than 70, is it really hard to achieve? I just curious.
No, it depends on if you take the right medicine. There's different kind of statin. The newer statin have more effective.
Okay.
Lipitor is the first one came along. It's effective, but it's not as effective as some of the newer ones.
Okay.
But each statin have its own side effect, and Asian are more susceptible to some of the side effects, like elevation of the muscle enzyme or elevation of the liver enzyme.
Okay. And then the D is diet and supplement, meaning that you have to do a low carb diet to make sure that, you know, you don't get over 150 gram of carbs a day, that you always keep your blood sugar low. That's really wonderful. And then E will be exercise. That means you have to do at least 150 minutes of exercise in 1 week. So maybe 10,000 steps per day, or 4 times a day, that you should at least achieve that. So this is really a very good take home for everybody from Professor Chan. A, B, C, D, E. A1C, blood pressure. B is blood pressure. C is cholesterol. E is diet and supplement. E, exercise. Another question from Eugene Young from Hawaii is that, Dr. Chan, is there a concern that should be measured capillary blood pressure? How does it done?
I just use it as an analogy. There's no need to do that.
Okay.
The measurement of the urine protein and other things is indirect. And complication of diabetes is like a micro. So diabetes effect on blood vessel is 2. One is called macro. Macro is large vessel, which is the blood pressure you can measure, arterial sclerosis, and coronary artery you can see. But microvascular complication, in a way I call it microvascular hypertension. Is hyperfiltration is the capillaries actually have high pressure. And we do that in research by micropuncture. We actually do that, but that's only in experimental models in laboratory. And nowadays we don't need to do that because we have so many molecular and chemical method to measure from the blood and urine. But microvascular, complication. Number one is kidney. Number two is eye complication like retinal hemorrhage, visual problem. The eye complication of diabetes are microvascular. Indirectly, neuropathy is in a way semi-related to microvascular complication.
Okay, that's good. Thank you. Well, I think, Eugene, we have answered a question. Anybody from the floor anymore? Any more questions? I think those are all questions are very good. But importantly, really take home is preserve your kidney. And there's so much more room you can able to do things like lower your blood sugar, exercise, take care of blood pressure, cholesterol, and with diet control, you can preserve your kidney. I hope everybody can take home with that. And that way you'll not end up with dialysis. And remember, A, B, C, D, E. That's probably one of the best sort of information for all of us to remember. And so easy to let people know to how to do our prevention here. Okay, if there's no more question, I really appreciate Professor Chan. Such a great talk about DKD and how to prevent it. And I think a lot of our audience already say a lot of things. So thank you very much. A lot of people say really, really helpful for them to understand the message, easy to understand, and go from there. So if you have no more questions, you can also continue to write to us. I flashed the screen just now. And if you really have no more questions, then we'll be ending our webinar. And I want to thank you again, Professor Chan, for this really informative talk. I think will help so many people. We will send this webinar to many different people. And Eugene said, thank you, aloha, love the format with my Hawaii friends. Wonderful again, Larry, appreciate it. Professor Chan, thank you again. Thank you for all my friends from all over the world, from people from Hawaii, Vancouver, Los Angeles, Philippines, Hong Kong, Singapore, Malaysia. Wow, there's so many different people. And thank you again. I really appreciate you spending time with us. Thank you. Okay, you take care. Have a very nice weekend. Thank you. Bye-bye, Larry. Thank you. Bye-bye.